Hi, everybody. Good evening. Thank you very much for joining us tonight. I have to say that we've had an overwhelming response to this event, which is both good and bad. Good because it gives us an opportunity to connect, but also bad because it's indicative of the amount of information and education that we're lacking out there in the CML community. So those of you who don't know me, I'm the executive director of the Canadian CML Network. We run out of Toronto, but we're national, and we provide support to people with CML and their families, as well as transplant survivors. So tonight I'm joined by Dr. Jeff Lipton from Princess Margaret Cancer Center to go through a little bit about COVID-19. As you know, it's been a crazy time. I hope you're all keeping safe and well. For myself, I'm barely keeping my spikes up and my butt is getting bigger as the days go by, but otherwise things are good. I think one of the most frustrating and stressful things about COVID-19 is that we're just not sure what the risk is. So thank you for taking the time to send in your questions. You'll see on your screen that you have the ability to type in questions if you happen to think of something as we're discussing COVID and the risk to the CML community. I think that one of the things that Dr. Lipton will go through today is an overview of COVID-19, as well as the impact that it has on the CML community. And I guess our chief concern will be to figure out what is our risk. So hopefully by the end of this session, you will have enough information to measure your own risk. I've been hearing a lot from many of you. And there's a big difference in terms of how people are perceiving the risk of COVID-19. Some of you are hanging out in your basements and not socializing with your families, getting your dinners delivered to your door, and others are not sure what to do when you go grocery shopping. So hopefully we can clarify all of that. So feel free to pass on your questions. And before we get started, I just wanted to say a quick thank you and shout out to Lampion Health Communications, who have been absolutely amazing in terms of arranging this video call. And of course, a special and big thank you to Dr. Lipton for taking time out of his evening to join us today. So we're going to start off. I'm going to ask Dr. Lipton to share with us a bit of an overview of COVID-19, what we know so far, and what has been its impact on the CML community in Canada, if anything. Thank you. Over to you, Dr. Lipton.
Well, thank you very much, Lisa, and welcome to everybody who's joining us tonight. It's a big question, and for starts, I think I will refer people to the International CML Foundation website, which has gone into COVID very recently. What's the big impact? I think the biggest impact is how people are dealing with themselves in terms of their visits to doctors and how they perceive themselves in terms of their risk. We don't know, bottom line, that there's an increased risk for COVID in CML patients, at least if you're in chronic phase on treatment. And that is the big thing that I think you all have to realize. We don't, as CML treaters across the world, and when there's a statement on the ICMLF website, do not think that the risk appears to be greater for a CML patient. What does that mean for you? It means for the average CML patient, what you really have to do is take the same precautions that anybody else would. Nothing special. There's a lot of there's a lot of misinformation out there, which I think some of the questions that Lisa's going to ask a little later are going to deal with some of that. But I think the big thing is, for instance, I'm not having clinics. Some people at particular distance are not doing the appropriate blood work, the appropriate monitoring. That may be in part because people are afraid to see the doctors, in other cases because physicians have shut down practices or closed things. Other people are not sure about what to do with their drugs, and we're going to deal with that. So there's a number of issues I think we have to look at, but I think the bottom line right now is we do not think there's an increased risk for people with CML. So we're monitoring patients around the world. There's a network now of about 40 of us in major cities in a number of different countries. We have charted so far, and obviously this is not everybody, even in Canada. We've charted through the International CML Foundation about 60 patients who have been COVID positive. Mortality rate in that 60 has been about 15%, and a number of those individuals are in their 80s. The American Society of Hematology is also keeping track, and they've come up in the United States with about 70 patients. And again, a mortality rate of about 10%, not much different in many cases than is seen with people without CML. So I think these are big issues. In Canada, I'll be honest, with about 10 or 12 major centers communicating with me, we have one proven case in someone who's now recovered from the disease and one unconfirmed case, and that's it. There may be more. We're not in touch with every physician across the country who treats CML, but that's about where we stand so far. So that gives you some background. I'm not going to discuss COVID with you. You got enough of that online or on television or anything else, but that's really how it relates to CML in a general way. So now I'm going to turn it back to Lisa, and we can start on some of the questions.
Okay, so I'll go in a little bit of order here. There's been some concern about drug shortages, given the border closures, as well as some patients have been saying that when they go to the pharmacy, they can no longer get like their 3-month supply. They're only getting 30 days. Can you comment on that?
Well, I haven't heard of any drug shortages. There's two things at least are going on right now. Number one, in Canada, about 3 months ago, Sprycel went generic. And a lot of insurance companies and some of the provincial plans are saying you have to go on the generic instead of brand Sprycel. So that's one thing that's happened. We have no knowledge at all to suggest that the generic is any different than the brand. Item number two, and I can only speak for Ontario, is in order to prevent hoarding, the province of Ontario has decided that pharmacies can only release 1 month of any drug, not just CML drug, your blood pressure medications, your diabetes medications, your cholesterol medications. They're only giving out 1 month at a time with this idea that they're trying to prevent hoarding. So I've not heard of shortages. I've not heard of the no availability, but that's one of the reasons why there's a 1 month out. And that is at least in Ontario, that's a province of Ontario regulation.
Awesome. Okay, and there's a question asking about PCR testing, saying that COVID testing sometimes involves PCR testing. Do you see that this is going to impact the PCR tests that CML patients have to take?
I think the screening for COVID is very different from the PCR testing done in molecular labs. I think they tend to be done in different places. I can't speak for every center, but most of the screening is not done in the same place. And I don't think there's going to be any delay in molecular testing. What is happening is people are not coming to places where they can get the molecular testing done. And that's an issue.
Okay, when you say that they're not coming because of risk or their perception of risk.
Yeah, people are afraid to come. For instance, I can't get molecular testing done on one of my patients done in a private lab and necessarily sent into my lab at Princess Margaret. It may be sent somewhere else if it's picked up at a Life lab. Now, the assays vary from center to center, and in order to compare whether someone is doing the same, improving, losing response, you like to have some consistency in the lab because not all labs are internationally standardized or have the same sensitivity in terms of the assay. So number one, patients aren't going. Number two, physicians aren't making it available. So I think those two things are preventing the testing getting done. My patients, I'm saying come in. They can come into the hospital laboratory. They're usually out in 5 or 10 minutes. I'm not seeing them in clinic. They get the blood work done. It does processed in the usual way, and I call them with the results later. But this may
Okay, so
vary
I guess,
from center to center, physician to physician as to what's being done.
okay, so I think you're right. I think you bring up a really good point, and I'm sort of going to jump ahead just slightly because I do know of patients who are months overdue for getting to get their PCR tests because of that, because they feel that it's too risky to go to a hospital. So I guess so I guess many patients are weighing that risk, right? So that they got to make sure that their CML is still controlled. And then on the other hand, they're worried about the risk of exposure. So from what I am hearing from you, you're saying, yeah, you should be going to get your blood tested.
Well, I think, look, if you've got a 4.5 log reduction and you've had it for a number of years and you're out there and your physician is still doing 3 monthly PCRs, you can wait till 6. Even 6 months, you can wait till 8. Would I go a year without monitoring? No. And remember, monitoring is not just doing your PCR. Monitoring is testing for organ toxicity and other things that are going on. Monitoring is talking to your physician about whether you may have symptoms. A pleural effusion hasn't snuck up on you. Something else is going on. So it's more than just doing the PCR.
Right. So next question. How does the treating hematologist determine whether an appointment is to be handled by telephone or in person?
I think some cases it is regulated by their institution. Secondly, it may be based on the comfort of the physician. I'm aware of some physicians who don't like going to the hospital either, so that's an issue. So I think it's very individual. There's no uniform way that's being done. I know how I'm doing it, but I don't know the way I'm doing it's the way everybody else is doing it.
How are you doing it?
Well, I'm asking patients to come into Princess Margaret, go to the lab, which is on our 3rd floor. They're screened at the front door as to whether they're any risk of having COVID. They go to the lab on the 3rd floor, get their blood drawn, and leave the hospital immediately. Some of them are saying they're in the blood lab for 5 or 10 minutes, most. The population density is not great here because clinics are shut down overall. In terms of my clinics, I see a few patients, but I'm probably seeing less than 5% of the patients that I normally see face to face.
So this is a good time to avoid the 4-hour wait then.
There's no 4-hour wait in our blood lab now, that's for sure.
Okay, so the next question, I guess, has to do with protection. You're going to the hospital then. Do you recommend wearing a mask?
Well, I think now, at least in my hospital, the rule is you have to wear a mask. Everybody does, whether you're just passing through the halls and clinics seeing a patient. When we see patients, we're also supposed to wear the plastic face visors. I recommend a mask. I think that's standard. Bring a hand sanitizer with you. You don't necessarily need to wear gloves or anything like that. But yeah, I would wear a mask. And the other thing, of course, is you need to come on your own. For the most part, unless there's an issue with a particular patient, either they cannot move very well on their own, there's a language problem, they need a specific interpreter, accompanying people are not allowed in with them.
Oh, that's actually, now I'm curious. That's a question that I have. So if you do need help or you need someone to come and support you, how does that happen?
Well, you have to make contact with, when you make contact with when you're getting your appointment, and we fill out a special form which is given to the people doing the screening at the front.
Great. Okay.
But it has to be a good reason. Has to be a good reason.
Right. Okay. Thank you. Okay. What should people with a low white cell count, do if they have to work with young children?
Now, what do you mean by a low white count?
It's a good question.
I think one of the things is some people may have lowish neutrophils, but generally the type of blood cell that fights viral infections is a lymphocyte. Young kids, especially kids who are in daycare, preschool, kids who are going to school, carry infections all the time. What would you do with those kids before the COVID? does COVID change anything, particularly now that those kids, they're probably not leaving the house. It's unlikely they're going to pick up COVID by staying around the house unless you've got people coming into the house who may pass it on to them. I think it's the same precautions you would normally include.
Okay. Okay, next question. Once a vaccine is available for COVID-19, do you think CML patients would be recommended to get it along with the yearly flu shot?
Most definitely. But don't hold your breath. That's not going to be here for a year or so, minimum.
Oh my God. So we're looking at living carefully for the next little while.
Yeah. And I think we're starting to see in many of the provinces right now lessening some of the restrictions that have been there for a while. And there's a number of people who in healthcare who look at demographics of diseases like this, concerning that there's going to be a second wave. We've seen second waves with other viral illnesses. For instance, even have to go back, the big one people talk about, the Spanish flu at the end of World War I. Spring was hell, fall was double hell. So it's potential. You really need to practice safe living, even when things lessen up. I think the days of going to a football game with 40,000 people are not going to be there for a while. Big concert venues are not going to be there for a while. The kind of thing where there are mass numbers of people are not going to be there for a while. So people are really going to have to be careful.
So I guess along those lines, it's this whole concept of risk and people's perspective of risk. And you're saying that, as long as your CML is controlled, that you're pretty much looking at the same precautions as everybody else is. So if you're in your house, like with your family, do you think it's necessary to isolate yourself, for example, from if one person's going out to get groceries, for example, does the person with CML, with controlled CML, need to take any extra precautions at all? I just want to make it super clear for everybody, so that they can measure their risk.
I think if the person going out, probably masks going into the store, washes hands regularly when they come back in. I'm not sure that that's the way people are picking up COVID, very honestly. People tend to be picking it up in dense concentrations of people. I think if the person doing the shopping should not go at prime time. They should go at a time when the crowds are less. They may be allowed into a store earlier, like seniors are in many of the big grocery stores earlier in the morning before anybody else does. Keep safe space, wash hands going in. I'm not sure that the risk is any greater for that person passing it on to someone at home with CML versus passing it on to anybody else at CML. Look, who's got COVID in Canada? The majority. They've been the people in nursing home, retirement homes, some healthcare workers, things of this nature. It has not generally been the people who have not, the ordinary guy in the street. There have been some groups of individuals who have not followed the safe practices of isolation, who passed it on. But in general, the average individual is, I think, being very safe. So I think it's probably, you don't have to separate yourself from that person, I think.
Okay. Okay, now there's a question about healthcare workers and you. What's the environment like? Like, how are you guys holding up? How is it working within this pandemic?
It's tough. It's really tough for a number of different reasons. There's an awful lot of stress on people. You feel disconnected from other workers. You feel disconnected from your patients. This is the biggest issue that I think we're finding. We have concerns about people who you think probably should be coming to be seen or getting blood work done who are deciding they're not doing it. I've had a lot of discussions and even arguments with some of my patients as to the safety of things. It's adding up. I think we have the appropriate protective equipment, at least in our institution. I'm not sure that was always the case everywhere, but I think people are getting a lot better about that. I see patients who have to be seen. I see new patients who've been recently diagnosed who I think have to be examined and have to be monitored a little more carefully. It's not just blood work. So be careful. You play it smart.
Mm-hmm.
But it is a lot of strain. It is a lot of strain. And I am aware of some of my co-workers who are not showing up as often maybe as they should be.
Mm-hmm. Yeah, I can imagine the stress level is probably at an all-time high. And, and I don't know, do you feel like as a healthcare professional, do you feel that in general there's like a good knowledge of COVID? Because for me, I feel like every single day they're discovering something new about it. And there's still so much that's unknown, even though we're, 5 months in or something like that.
Well, there's a lot of things obviously we still don't know. And we still see, for instance, the incidents creeping up and things of this nature in certain places. And we've now, in the last few days, seen maybe a second wave developing in China. So big questions is once you've had it, can you get it a second time? Are you immune having had it? There's an awful lot of primary care physicians, at least in the Ontario area, who've just shut down their offices. People don't know where to go. They don't know where to get their prescriptions renewed. They don't know where to get their appropriate healthcare monitored. There's support workers, a number of things that are not seeing patients. Chiropractors are not seeing patients. Chiropodists are not seeing patients. A lot of routine stuff is not being dealt with right now. One thing for sure is very interesting is that our emergency rooms, which are usually bulging with patients, are now down to 5, 10, 15 patients at a time, which tends to make me wonder is, A, are people who should be coming to emergency room not coming? Or B, which is more likely, a lot of people use emergency rooms as drop-ins and are probably not going right now because what they're doing is not very serious.
Mm-hmm. Mm-hmm. Yeah, I don't know. I think it's actually the opposite. I think that people are so scared to go to the hospital that they're opting to stay at home with health conditions that probably need care, which is not the smartest thing.
You're right on a lot of cases, I'm sure.
Yeah. And it's not helpful, especially because we don't have an idea of when this is even going to end. So, yeah. So if anyone's listening and you've got something that you think is urgent, you got to go get it checked. Don't wait.
Go to the emergency room, please.
Okay, next question. What effect, if any, does the current crisis have on accessibility to procedures such as stem cell transplants?
That's a great question. There was one transplant center in the country that had a COVID outbreak and shut itself down. We are doing fewer, definitely, because we're screening fewer people. We're seeing consults in fewer. We're probably working at a rate about half what we did. So if you've got a real urgent need for a transplant, acute leukemia or something like that, aplastic anemia, you're getting it. People with more chronic disorders, such as myelofibrosis or something like that, are being delayed a little more. Where we're also seeing an issue is getting in grafts. There's some countries that have completely shut their doors to people picking up stem cell grafts. We've seen cases where there may have been direct flights between a country and in Toronto where those flights don't exist. So couriers are having to make multiple stops along the way, which is slowing down the rate at which your graft will get here. It's having an impact. No one is doing as many transplants as they were. So it is an issue. Hopefully the urgent ones are being done, but I'm not sure necessarily that's the case. In some cases, I expect as well that some donors may not be willing to go into harvest or a collection center and get processed right away.
Hmm. Yeah. So,
And
I mean,
there were countries, for instance, where you had major outbreaks. In Canada, we draw a lot on Germany and Italy, and those countries had massive outbreaks that basically shut things down to get any kind of donor for that for a while. Things are revving up. The Germans have been absolutely marvelous, but other countries have slowed down a lot.
well, and no wonder patients are so stressed out.
Mm-hmm.
I'm wondering if you've had a transplant. Then that's a whole different story. Then, in terms of your precautions you should take, right?
That's a very different situation because now you're dealing with people who are quite immunosuppressed, particularly against viruses, particularly earlier on in the transplant. That's a very different. Those people are more susceptible to all viral infections. That's why we absolutely beg them to have flu shots and vaccinations when they do. And we have some who are very stubborn. We have anti-vaxxers in the patient population who are absolutely stubborn about not doing it. And I've had at least one case where they've gone on to get pneumonia and get very sick.
So in the case, so I'm going to ask a question because I know there are some people who have had transplants about a year out who are on the call. And for them, in terms of, managing risk within their household, should they take extra precautions in terms of, their partners or their children? Or is it just basically the same thing? Just make sure you wash your hands, be super, careful if you have someone who leaves the house.
You've got a big spectrum of people here. Remember, there's some people who are still earlier on, who still may be on drugs to suppress their immune system, who may have things like graft versus host disease, which is immunosuppressive, who haven't properly recovered their blood counts. They tend to be at a higher risk than someone who's maybe out a year off all medications and doing a little better. Despite that, I think those are individuals who should take a little more care. Definitely, if you're in any kind of immunosuppression, you need to be very careful about people who go out, people coming in, people who are sick. Just like you would be in the influenza season, the same situation. The difference being with influenza, at least we have some treatments for many of these. I think those people need to be a lot more careful, even a couple of years out. Someone who's had a transplant, immune system may be good, but it is never as good as someone who's not had a transplant. So a little more care a little more smarts are probably necessary.
Okay. And if someone wants to know what the supply of protection, personal protective equipment is where you are, has it been okay?
Well, if you come into the hospital, you're given a mask. Everybody.
What about
staff?
What about the health workers?
Yeah, we all have masks. We have to wear masks all the time. Except when I'm sitting in my office now with the door closed, I don't wear a mask. But if I go to the bathroom 20 feet from here, I have to wear a mask going there. So we do have it. I think there's hand washing everywhere, hand sanitizers everywhere. There's gloves for certain things. If you do procedures, there's additional or scrubs, gowns, face visors. I think we have it. There's a lot of things that aren't being done, though. Elective surgery, we're so far behind. We're tens of thousands of cases behind in elective surgery across the country.
And I've been hearing a lot of stories about people who have like serious cancers, like tumors that were planned to be removed, for example, or and those surgeries have been delayed. Do you have any insights on that? Like, is it a healthcare professional? Yeah.
I think that's
not
true.
Right.
I think, for instance, I'm aware of breast cancer patients who are, instead of getting their primary lumpectomies or mastectomies up front, are being given chemo because the ORs are closed. I think, particularly when it comes to surgery, that is the case.
And I mean, hopefully that's going to change soon, right?
I hope so. But it's going to be a matter of balance. For instance, if in the past the procedure was to get a mastectomy and an immediate reconstruction, hopefully they will get all the people who need the mastectomies done and worry about reconstruction later. And I hope the individuals who have to unfortunately have these kind of procedures are going to understand that. That's going to take a while for the cosmetic improvement to be done. But in the meantime, they have other individuals who need basic surgery. Let's get that done.
Yeah, I agree. I mean, I've been hearing a lot of discussions about triage, like these decisions that are being made for cancer patients in terms of like some will get the treatment that they need right now, depending on the severity of their condition, and some won't. So it's really interesting. I think it kind of highlights how our system is broken in many ways when it comes to this stuff.
Well, is the system broken, or the system is stalled just because of the concerns and the risks? So I think if you need immediate surgery, I think you're going to get immediate surgery. If you've got surgery that maybe can wait a little bit, I think that's what's happening. And if you've got surgery that can wait a little longer, because the biggest issue, for instance, benign surgery, you need a hip replacement, you need a cataract done, this kind of thing, you need some plastic surgery done, that's going to wait. That's not life-threatening. It may be annoying, it may be painful, it may have an impact on your quality of life, but it's not going to kill you. And that's going to wait. That's not going to be done.
Right. Okay, if a CML patient is diagnosed with COVID-19, how important is it for their treating hematologist to be informed?
About COVID? I think
Yes.
it's extremely important. I think there's some myths out there as well. Number one, about the risks. Two, there's some myths out there about what drugs you should take, shouldn't take. Some have actually suggested that certain drugs not be taken. There's even some suggestion about switching drugs. I think the recommendations from a group of world experts, and I think, again, go to the ICMLF website, is stay on the treatment you're on if it's working. Don't stop or change a thing. I think any suggestion to the contrary is based on maybe some theoretical arguments, but not based on any hard evidence.
Okay. Okay, the next one. This has been in the news quite a bit. If you're on Sprycel and get COVID and have a fever for many days, and it probably doesn't matter if you're on Sprycel or any other CML medication, but what is the best fever reducer? Tylenol or Advil? I know there were a few reports that said for COVID-19 reasons you shouldn't take Advil. What do you have to say about that?
Well, I don't think Sprycel is any different from any of the other drugs, number one.
Yeah.
So I think if you have a fever, normally with none of the TKIs, we don't recommend a lot of acetaminophen because of the potential interaction. So depending how many you're taking, if you're taking up to about 2,000 milligrams a day, you're probably okay if it's just for a couple of days. Advil is good, drugs of that nature. I think whichever works best for your fever. We normally, with a TKI, I recommend Advil for fever pain and not acetaminophen, unless you have a headache for a couple of days. I do not think Sprycel is any different from Tasigna or Gleevec or any of the others.
Okay. Okay, so are flu and pneumonia vaccines recommended for patients over 60, especially in light of COVID-19?
I recommend flu shots for everybody, but particularly for CML patients. And I definitely think that people over the age of 60 should consider Pneumovax or Prevnar, one of the anti-pneumococcal vaccines, without a doubt. And I think it's got nothing to do with COVID. It's got to do with preventing pneumococcal pneumonia, which is a killer. Look, in Ontario, we have 300-400 people a year die from the flu, and they're mainly older individuals. I think flu shots are extremely important. hopefully we will have a vaccine against COVID, and that vaccine should be taken as well by all individuals. I'm a senior. I got my flu shot, and I got the seniors flu shot, and I've had Prevnar, and I've had Shingrix against shingles. And it's not that I'm recommending to someone else and not doing it. I've done it myself.
You're not a senior. No way.
Oh yeah. Oh yeah.
Okay, I'm currently a lab technician at Life Labs. In your opinion, is it safe to return to work if I have CML?
That is a good question. I guess the chances are that you might be more likely to be exposed to someone who's going in to get blood work done because they're sick goes up. I know a Life Lab that I personally use can be very crowded, a hell of a lot more crowded than my hospital blood lab. The potential for a problem is there. I don't know what kind of precautions they give you in that place. If you got totally gown, masked, gloved, everything like that, it's probably relatively safe. But again, you're more likely to run into a sick person in the lab getting blood work than you are on the street.
Okay. Okay. Is Princess Margaret testing patients for COVID, and is there antibody testing available?
Two good questions. Unfortunately, we're not universally screening. We are screening inpatients right now, pre-transplant, things of that nature. We screen people who have a history that's suggestive of either exposure or symptoms when they come in the door. They're all being screened, and that's a routine exam. Antibody testing is not being done anywhere as a routine. That's something I think needs to be done, because I think we need to know who's been exposed to it in the past, if they have antibodies, because it gets back to one of the points I made earlier, is do antibodies protect you against reinfection? That's a big issue. We also, in terms of, one of the things we talk about is having enough people with antibodies that it provides immunity to the community. So we need to know, is there a critical number of individuals out there now who've been asymptomatically affected? Remember, it's not the sick COVID patient who usually passes it on to someone else. It's the person carrying the coronavirus who doesn't have symptoms who passes it on to someone else. We don't know how many people have actually been exposed. We don't know how many people have it. The only way we'd ever know would be to do antibody testing, and that is not a routine test anywhere.
Mm-hmm. Okay. Okay, we have an MPN question. If an MPN patient is diagnosed with COVID-19, are the chances of succumbing to the virus greater than in the general population with otherwise similar risk factors?
Again, it depends what MPN you had, what the state of your blood counts are. Again, the MPN drugs that are out there, and I'm assuming you mean drugs like Jacobine, things like that, tend to be not immunosuppressive. It's actually very interesting is there's some studies going on where at least one of the JAK2 inhibitors that's out there in trial is being actually tested as an anti-COVID treatment. There's some theory that some of the medications used to treat myelofibrosis, some cases, some of the other diseases may in fact help against COVID, but that's too early to know that for sure. But I don't think it's an NPN patient unless they have no blood counts or had a transplant or something like that. Is much more at risk than the general population. Again, the numbers at least I've seen do not suggest that either.
Okay. Okay, I think you've already answered this question, but I'm going to ask it. If you are in a controlled CML state, are you considered immunocompromised?
No, not significantly. Not to the point where I would think you're much worse off than the general population. And that is the opinion of an international group of experts. Now, if you have advanced disease, if you've had a transplant, if you're on other chemotherapy, different story. But if you're chronic phase CML, Well, even if your chronic phase CML, whether your log reduction is 1 or your log reduction is 4.5, CML is a clonal production of normal blood cells. They are present. They just come from a CML clone, and they do function. So you're not immunosuppressed like you might be for the other diseases. Now, some people will argue that are some of the drugs immunosuppressive? The answer is probably no. Some CML drugs are being used for other reasons, for instance, post-transplant for other reasons, but not for their immunosuppressive properties.
Okay. So if someone says to you, hey, are you at risk? We can safely say we're just like you, sort of?
I think so.
Except cooler? Yeah? Okay. Awesome.
Sorry?
I just said, except we can say that we're cooler than they are.
Mm-hmm.
Do you have any ideas on how to keep your immune system strong?
Well, having been in a pharmacy and looking at the empty shelves for things like vitamin C and B12 and all these things, you know what? None of that stuff has been proven to boost the immune system. I've noticed on television, as well as all the pharmaceutical companies that make all these drugs for supposedly boosting the immune system, there's no proof for a lot of this. I think the best way to improve your immune system is to make sure you eat well and take care of yourself.
Okay. And that includes like exercising and sleeping.
Exercising, yeah, if you're used to long distance running, you're not going to be able to do that inside, but eating properly, trying to sleep properly, not over abusing other things, not smoking, or not using too much alcohol, etc. It's the usual things that you would tell anybody for good health and to protect their immune system, I think is the best way. I'm not sure there's any pills you could take that are going to boost your immune system. And even things like echinacea, which if taken early, might have an effect on the flu. There's no evidence that it works with COVID.
Okay. Okay, next question. I was told to head to the emergency room if I have a fever of 38.2 or higher. Is this still the case given the pandemic?
I'm not sure for a chronic phase CML patient, I would necessarily tell them. For an acute leukemia patient who doesn't have blood counts, yeah. I wouldn't tell anybody with a temperature 38.2 to go to the emergency room if they're chronic phase CML.
Mm-hmm. Okay.
Even if it wasn't a COVID, I wouldn't tell them to do that. So I'm not sure where that information came from.
Okay. Is COVID-19 having an effect on clinical trials, either the ones that are underway or the ones that were in planning stages?
Definitely. Everything's on hold. So we're not getting a lot of follow-up information on some of the studies, including CML trials. We're not starting new ones. We're not enrolling patients. It's a big issue because, number one, most places don't allow you to draw research blood. You're not allowed to follow up patients, or you should be. It's had a big effect on that aspect of things. Summer students who are going to be hired to do research, all off. People are being told not to go into research labs, all off. Big thing.
Okay, if you've had a good response to Sprycel and then you get COVID, should you discontinue Sprycel temporarily?
No. That myth is out there. And I know there's some physicians who I've heard of be telling patients that the answer is no. Do not stop any of your medications.
Okay, no matter what.
Well, obviously, if you're on a ventilator and can't take your pills, a different story. Mm-hmm. But stopping your medication because they think it's going to protect you or think it's going to improve your recovery, the answer is no.
Okay. And actually, this reminds me of something that I had heard a couple of weeks ago about some CML drugs, some TKIs being potentially protective against COVID-19. Have you heard anything that has to do with that?
Yeah, that was out there for a while. I'm not sure there's any evidence of that. As I said, there's a similar type of drug that There's a little more research being on, and that's the drug for the myeloproliferative disorder, MPNs, that are being looked at in some studies, but not any of the CML drugs.
Okay.
And that includes, what some of you may have read in the paper, interferon. There's a big splash in the last couple of days in the paper about interferons, and maybe it has some work against COVID. Number one, those are beta interferons. The drug interferons we use for treating CML are alpha interferons. They're very different. I know there's some patients who are on interferon, usually because they're in some process of being pregnant, trying to get pregnant, something of that nature. No evidence at all that alpha interferon does this. So we don't want people to switch over to interferon necessarily.
Okay, next question. If our levels are okay when the countries open their borders, can we safely travel?
I think you could safely travel the same way anybody else can safely travel. I don't think you're more at risk than anybody else. When it's deemed safe, depends what you're traveling for, then you travel. Mm-hmm. Look, I'm not traveling. We have a grandchild, our first one that was born a few weeks ago down the States. Haven't seen her yet. It's one of those things. Aww. I don't have CME.
Yeah. Okay, next question has to do with more of a general CML question. So it says, in the last 3 months, I've been on 3 different brands of generic imatinib. Is it better to stay with the same manufacturer? Is it okay to have 3 different versions of the same generic?
Oh boy. Let's talk about the reality of this. There have been a couple of cases since the generics came on the market in 2013 where one has not been available. This has happened with the Apotex product several times, and for the last half year or so, for some reason, the Teva product has not been available, which is interesting because there's places like British Columbia which have contracted with Teva. One of the things that a lot of the commercial pharmacies do is they buy whichever generic is the cheapest, and that's the one they distribute. So they can make $10 extra off the wholesale price, and I'm going to be totally nasty about this. I'm not sure there's anything different in the active ingredient between the generics that are out there. There is some difference in the filler that's available that may make one drug a little less tolerable for someone than another. I tend to tell my patients that if you've got a generic that works, unless your particular drug for some reason is not available, stick to the same generic. And you should insist on that with your pharmacy. The pharmacies are only switching brands because of how much money they can make. And for $10, it's crazy, but that's what they do. Okay. So push to one that you're comfortable with. Because I've had people say, I'm on drug X and I didn't like it, went to drug Y, and wow, I tolerated it. Now they want to put me back on drug X. No, stick with drug Y if you're finding it's giving you less side effects.
Mm-hmm. Okay. Is there any evidence for the use of hydroxychloroquine, and is it okay with all TKIs?
There's no definite evidence. That's something that's been out there. People are investigating it. Hydroxychloroquine is not necessarily a safe drug. It has a lot of side effects. It's a drug that's a derivative of a drug that was used originally to treat malaria. It's used to treat autoimmune diseases, and it can have toxicity, particularly to the retina of the eyes. It can be used with TKIs. I've got a couple of patients who are on this drug because of autoimmune diseases such as lupus, who are taking them in combination. They have to. There's no evidence that it is a prophylactic treatment against COVID. So I think it's a big risk to take this drug just offhand. Whether if you need to be treated for COVID, I think that needs to be done under a controlled set of circumstances and by people who know what they're doing. It's not something to play around with.
Okay. All right. Would someone who typically has an overactive immune response, like food allergies, have a bigger response to COVID-19?
I can't answer that. I don't know.
Okay.
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 You would think that if you have a good immune response, that would be great in clearing the virus. We don't know in terms of the people who get very sick and unfortunately die, whether a lot of that is because of not necessarily the virus, but what their own system and turning on their immune system has done to things like their kidneys and their lungs and other things. So I don't have an answer. I'm really theorizing right now.
Mm-hmm. Yeah, I don't know that most experts have a good handle on COVID and how it behaves in the body, because it seems like it behaves differently, and like they can't say for sure how each person is going to respond.
I think we do know one thing, since most of the people who get very sick, and unfortunately most of the deaths tend to be in seniors, in people in places where there's more infection. We definitely know that as we age, our immune system gets less vibrant, shall we say. That's probably one of the reasons that older individuals don't do as well as younger ones who get it. So there's definitely the weaker your immune system, probably the more you have a chance of getting into trouble if you get an infection. I don't think it necessarily means you're more likely to get an infection, but you'll get worse effects if you do get an infection.
Right.
To get an infection, you have to be exposed to the virus. Okay?
Right.
If you've got zero immune system and live in a bubble, you're not going to get COVID because you're not exposed to the virus.
Okay. Okay, a question about how blood clots are being seen. There have been some reports about young people showing up in emergency rooms, having blood clots or strokes, and then later finding out that they've been exposed to COVID. CML patients are supposed to take Advil as opposed to Tylenol. Do you have a comment on not using Advil to avoid these clotting difficulties?
Advil doesn't cause clots.
No,
so
but
I'm not
doesn't
sure where
it thin?
that's coming from. No,
I think the person says thinning the blood.
it may increase the chance of somebody having a bleed for some reason, but I don't. It's not like aspirin, which is used to decrease platelet function and might produce the clots. I don't think, unless someone is an Advil abuser, that they have a higher incidence chance of getting clots. High chance maybe of getting a bleed if they overuse it, but I don't think there's
Okay.
I just don't have an answer to that either.
Okay. I vaporize cannabis as a medication to counter the effects of imatinib. Would that have any effect on my immune system?
Well, some of you already know my feelings on that there is a potential drug interaction between cannabis and TKIs. Is it immunosuppressive? I don't know. One of the things we do know is putting things in your lung, cigarettes, vaping, anything like that, does affect the integrity of the lung. It affects the cilia that line the lung, which help the lungs clean out infections. It does all sorts of things. And there are now a number of different reported of pulmonary problems related to vaping or inhaling. Theoretically, if you have an infection, it may make it worse. but I think it will make any infection worse, not just the COVID infection.
Okay, so someone's looking for some clarification on the discussion that we had about Sprycel. It says, please clarify, Sprycel was developed as an immunosuppressant, but it doesn't suppress CML patients' immune systems. Is that correct?
Correct. That is true. Bristol Myers, when they developed Sprycel, was originally a failed immunosuppressant. It sat on the shelf, but in a massive screening, it had activity against CML. Sprycel is not used as an immunosuppressant because it doesn't work very well as immunosuppressant. There are some people who argue maybe more infections. There are a couple of the initial studies with Sprycel, the one done at MD Anderson and the Decision study, which is randomized, showed a very slightly higher incidence of bacterial infections on people who got the Sprycel compared to imatinib. But it is not an immunosuppressant. We don't use it as an immunosuppressant. In fact, one of the things we do in transplant patients is for people who have certain types of graft versus host disease, we actually use imatinib because it has an anti-fibrotic effect. So it works in some people who have fibrotic graft versus host disease. No one is trying Sprycel or dasatinib for that.
Okay, so all right, the next question is.
And sorry, just one of the questions. Some of the data that's being collected by the International CML Foundation, there's no preponderance of one drug in terms of the 60 or so patients who've got COVID. In fact, the most common drug that these people are on has been imatinib. But there's more people with nilotinib than taking dasatinib who've got COVID. So nothing to suggest that dasatinib or Sprycel is more of a risk.
Okay. Okay, so another question about Sprycel. Now that Sprycel is generic, my pharmacist is recommending that I take the generic, but given the pandemic, I don't really want to be experimenting with it right now. Should I go ahead with the generic?
Okay. So there's two parts to this question. Is number one is who's going to pay for the drug? Now, I've noticed in Ontario that Ontario Drug Benefits and virtually all the private carriers have all said you must take the generic. No question. It's not as if you have a choice. If you want the brand, you can take it, but you have to pay the difference between the two. So it's a big issue. If your pharmacist is just recommending it, but you have coverage for both, why take the generic if you can take the brand? The generic is new. There's only one generic available in Canada made by Apotex. It's only been out for around 3 months. Have we seen any problems with it? The answer is no. We know if it's less effective, if there's more side effects, no. But virtually all patients are being shifted over because the carriers won't pay for the brand. So I guess if you have a choice, well, take the brand. If it's not going to cost you anything or you could afford to do it. But you may have just because the pharmacist is recommending it, the pharmacist may be telling you that your insurance won't pay for the brand, which is a different story. If you're on Ontario Drug Benefits, you won't get the brand. And Bristol Myers, which had a support program for people who had co-pays or insurance or something like that for the brand, that's been discontinued in the last few weeks. So if you were having additional support through Bristol Myers, that's now gone. So
I think actually it sounds like the concern was more about whether or not like taking the generic would be at all risky during a time when, maybe she's not getting her testing done as often because of COVID.
Again, we don't think you're more at risk because you have CML. Not getting your testing is not what I would recommend. Suppose,
generic,
I don't know if this is, suppose their insurance is not going to cover the brand. What are you going to do? You could be out thousands of dollars just trying to supplement the brand. Is that what you want to do? I don't think you're more at risk. We have nothing to suggest that the generic is not of quality. We know when the generics came out for Gleevec, everybody was worried. There were some reports that perhaps maybe the response wasn't so good. I know there was a study done out of the Jewish General Montreal who suggested that, but I had hundreds of people who were forced to switch because of who their carriers were, and I didn't see a single one who lost response.
Okay, question about going outside. Would you wear a mask when you were outdoors?
Look, if you're outdoors walking on your own, you're not going to pick up a virus from the air. It's a droplet thing. Where the masks that become particularly important is when you're around other people. So if you're just going out into your yard or going for a walk on the street when there's no one around, I'm not sure a mask gives you any advantage under a situation like that.
Okay. Thank you. Okay,
It's interesting. I watch people walking alone in the streets wearing masks. I'm not sure. I don't think people understand the role of a mask. This virus is not in the air.
Yeah.
The virus is not in the air. The virus is droplet. So you've got to be around someone who's coughing up or sneezing up droplets or something like that to be exposed. And in the air, it settles fairly quickly. It doesn't sit around, so it's not going to happen.
Okay. Okay, next question. Do you see any concern with staying inside for long periods of time and not being exposed to general viruses?
No. I don't. I think the biggest thing is staying around inside, as most of us are probably going crazy. I think there's a lot of people who are not doing very well being inside. There's a lot of people who aren't coping. There's a lot more violence now, particularly against women and children. That's an issue. I think if getting outside helps break some of that, but I think it's important to get outside. But again, you don't pick up viruses just from being outside. You pick up viruses from other people.
Okay, next question. For the treatments that are used to treat the symptoms of COVID, like when you're hospitalized, for example, are there any concerns regarding interactions with CML medications?
Well, I think if you're in hospital and being treated for COVID, that is a very different situation from being at home and thinking you should take something. In the case when you're in hospital, the potential for drug interactions with some of these drugs is there. And maybe that's a time where you might go take a drug holiday for a few days. Remember, a lot of people who get into hospital are very sick. So that's a different story completely.
Okay, so we have just a few more questions left. So if anybody has something that's burning in their minds, if you want to go ahead and type it up, that would be great. We have about 20 minutes to go. So we've got another question regarding the generic. So apparently it's been difficult to get the same generic. There seems to be a shortage. Somebody says, have you heard of any shortages of generic?
Well, as I said, I know since 2013 there have been at least 3 occasions where Apotex was not available. And for about the last 6 months, the Teva brand, for some reason, has not been available, which is an issue because I know several of the provinces, including British Columbia, actually contracted with the one generic. And that's what is issued through the BC Cancer Agency. So I don't know what they've done in a case like that. But yeah, there have been some shortages and production problems for some reason. Those 2, I haven't heard. There's 2 other brands that are available in Canada. One is the ACT brand, which isn't very common, and the other one is the NAT brand. And I haven't heard anything with either of those.
So if someone's at their pharmacy and they realize that there's a shortage in the brand that they need, what would be something that you would suggest? Like, what advice would you give them?
Well, you don't want to stop your drug. And I think all the brands, as I said, I think the active part of all the generics is fine. It's the carrier. In some cases, it may be cellulose, some drugs, it's lactose. You may have different tolerability due to the carrier that's there. If you can't get the drug you have to get, and there's definitely a shortage or it's not available, number one, make sure that it's not an issue or this is the brand we got the cheapest. Number two, make sure that your pharmacy is just not negotiated with one specific wholesaler who's only going to supply one brand. The threat, you've got a drug that's not cheap. The threat of going to another pharmacy or place, if it's an option where you can get the brand you want, is enough very often to get a pharmacy to bring in what you want. But if definitely, for instance, Teva, I know is not available. My pharmacy, for instance, at our hospital is great. If you've started on Apotex, that's the one they will issue each time. But you start in Teva, but I'm getting these calls. We can't get the Teva. We know it's a short supply. You have to take something different. But try and make sure that something different is the same thing. And then you make a choice. If you're on it for an extended period of time and you like it better than the brand you were originally on, then stick with it. Don't go back to the original brand when it becomes available. But don't go bouncing back and forth. And make sure you're getting a straight answer from your pharmacy.
Okay. Excellent. Okay, so regarding the vaccine, general vaccines for flu or COVID, how do they work? And does it ever affect blood composition and the way your medicines are absorbed?
No, vaccines don't touch medicine absorption at all. So that's the first thing. Number one, a vaccine works, and there's two different types. There's different ones. There's a killed vaccine, or there's a live attenuated vaccine, or there's synthetic vaccines, and they work in different ways. But basically, what they do is they stimulate your immune system to either make antibodies against whatever that vaccination is, or it stimulates your T cells, which is a different way of your immune system working, to act against that infection if it ever sees it. So they stimulate your immune system. Vaccines work in CML patients. And despite a lot of the myths that are out there about vaccines, they're generally pretty safe.
So people who are in TFR, so if they're on therapy-free remission, are they able to fight the virus?
Which, COVID? Or
Yes.
any virus? Well, even if they're not in TFR, even if they're still on their drug, even if they're newly diagnosed with CML, you should be able to fight an infection. Now, why some people are asymptomatic with COVID and never know they had it, and why other ones die from it, is a question of the aspects of their immune system, but it's got nothing to do with whether you're on treatment or off treatment. Generally, your immune system is pretty good with CML and chronic phase.
Okay. Okay, how am I going to know if I have symptoms of COVID when the side effects of imatinib cause headaches and muscle aches, pretty much the same symptoms, symptoms of COVID?
Well, remember what the main symptoms of COVID are: fever, cough, headaches, generally feeling unwell. They're not specific to COVID, they're specific for viral infection. Mm-hmm. Again, it would be something that would be a break in your normal symptom profile. So things would be a little different. For instance, if you're not getting high fever, suddenly you're getting high fevers. Night sweats is another big thing with COVID. If you've never got night sweats before and suddenly you do, that's potentially a symptom of COVID. But if nothing changes, then there's no reason to think that you've picked up COVID.
Okay. Okay, so the next question is, can children or anyone who do not show symptoms of COVID-19 be carriers?
Definitely. I think most of the COVID is being spread by asymptomatic individuals. That's a big issue. And kids carry. And let's be honest, particularly uh, pre-kindergarten kids, if they have a daycare or something, they pick up everything, and you get it from them, especially if it's your first kid. So that's a big issue. And there's now actually they're looking at kids that there may be an unusual sickness that some of them are developing in the pediatric population. They're starting to question maybe due to COVID. So they get this really nasty downstream effect without having had symptoms of COVID. So yeah, it's possible. But again,
Okay.
if the kids are not out and exposed to anybody with COVID, they're not going to get COVID. So if they've been locked up at home for the last 2 months, driving you crazy, no one's come in or out or anything like that, your kids don't have COVID. They can't give it to you.
Right. Okay, next question. You touched on Advil and Tylenol for fever, but if you have elevated creatinine, which would you recommend?
Good question again. When an elevated creatinine, the non-steroidal, such as the Advil, is not the one you should probably take. You probably should, in that case, take the acetaminophen. You just have to be careful on how much acetaminophen you're taking. As I said, usually about 2,000 milligrams a day for a few days is not a big issue. But if you're taking chronically, it's a problem. But yeah, there are some people who have an increased creatinine for many different reasons. Other diseases such as high blood pressure, or diabetes, or other things, or sometimes there's some people who may get high creatinine because they're on imatinib particularly. They're the ones who should avoid Advil.
Okay. Okay. So if I'm 64 and I am 2 weeks overdue for a CBC blood test for something else, but I don't want to go to a lab, should I go to the lab?
Again, I don't know what's being treated. I don't know what they're looking for the blood test. If you're an individual, for instance, who they're following you because you have a platelet count of 5 or something for some other disease, then you should go to the lab. If you've got, it depends what they're doing that CBC for. If it's a routine that someone is doing it every so often, well, maybe, and they're doing it every 6 months, waiting 2 weeks is not a big deal. But if you're someone for whatever reason is supposed to have a blood test done every 2 weeks and legitimate, and now you're overdue, that's a different issue. So without knowing anything about why they're doing the test or what they're looking for, that's a hard question to answer.
Okay. Well, and it all comes back to risk, right? And so I'm assuming that if you need to go to a lab and have your health taken care of, then if you're taking the right precautions, it should be okay. But definitely not worth sacrificing your health because of a perceived risk at the lab.
Exactly. Look, for instance, molecular monitoring, even in the patients who have the absolute best responses, I do the molecular monitoring every 6 months. There's some of my patients now, well, I've wanted to avoid things. I pushed it to 8 months. If they've got MR 4.5, they're probably going to be okay. If you're someone who's just starting out on treatment and I haven't got your blood counts under control and I don't know if your TKI's kicked in yet, your white count is shooting up, your platelets are shooting up, you're someone who can't afford to miss that blood test.
Okay. Do you know if you can get COVID by having sex?
There are a couple of reports about maybe, but apparently it is one of the least common ways of being able to transmit the disease. I think if your partner's got COVID and they're not breathing in your face or something during sex, we won't go into variations or things of that nature. You're more likely to get the COVID because they're sitting there unless they've got a face mask and a visor and everything else. I think if you know got a partner who know has COVID, is it really someone you should be having sex with? Anyways.
Right. Okay. Just checking in what the questions are. Okay, so I think we've answered this question, but is someone with a current undetectable molecular test at any increased risk if they become infected with COVID-19?
No more than the general population. And no more than the person who has no molecular response. Or no better than the person who has no molecular response.
The lung issues that are seen with COVID-19, are those pleural effusions?
No, I don't think so.
Okay,
I
so
think
if
the
you're at
lungs
risk,
are.
sorry, so
If pleural effusions are very different. Pleural effusions, remember, are not problems with the lungs. Pleural effusions, particularly with, well, dasatinib or Sprycel is the drug that causes this most commonly, although you can get it with all the drugs. It's actually because of a hyped up immune system. You get some kind of an infection, your immune system turns itself on, and the lining of the lungs called the pleura, which line the inside of the chest wall and the surface of the lungs, is an innocent bystander. And that's how you get the pleural effusion. So it's a hyped up immune response against the lungs.
Okay, so if you're someone who has has had experience with pleural effusions because of the TKI that you're on, does this put you at any increased risk of not necessarily develop or catching or being at risk for COVID-19, but in terms of recovering, does it affect your ability to recover?
That's a really good question. I think most people who get pleural effusions, the typical history, if you ask very carefully, is they've had a cold or the flu. And a couple of weeks later, they're short of breath, usually when they lie down or climbing upstairs or something, and lo and behold, they've got a pleural effusion. What they've got is an immune response to a viral infection. That's probably more influenza viruses or paraflu or any one of the normal viruses. Now, can that also occur to coronaviruses? Now, COVID is just one type of coronaviruses. There's coronaviruses all over the community, which are not the ones that cause COVID. That I just had one of my transplant patients actually show up with a swab positive for a non-COVID-19 coronavirus. It's out there. Can that virus stimulate the immune system to the point where you may get a pleural effusion? Theoretically, I would have to say yes. More so than another infection? I don't know.
Okay, so if I show up at the hospital with COVID-19, given that I'm at no more increased risk than anyone else, should I tell the doctors that I have CML?
Oh, definitely. Well, if you show up with an infection, you should tell the doctors a medical history. Not just to have CML, do you have any other kind of cancer? Do you have heart disease? Do you have a history of lung disease? Do you have a history of kidney disease? Do you have some kind of genetic disease? Keeping these things secret from a doctor is not a good deal. Now, whether it'll make any difference or not, probably not. But I think someone who's treating you who does not know your medical history should know what other, for want of a better term, comorbidities you have.
Mm-hmm. Okay.
Just like they should know what other medications you're taking.
Right. Can you tell us what diseases and conditions put you at most risk at developing a severe case of COVID-19?
Well, it appears to be number one, a disease a lot of us are going to face, all of us are going to face, that's called old age. But diseases like diabetes, heart disease, lung disease are all ones that are going to make, if you get COVID, make it worse.
Okay, I'm an elementary school teacher. I have low neutrophils and a low white blood cell count. Would you recommend returning to the classroom?
Well, again, I don't know why you have a low white count and low neutrophils. Was the first question. Uh, Number two, well, I guess the only people returning to the classroom right now in Quebec. Have you worked this way with other potential viral infections? Who are you? What kids are you treating? Are you treating preschoolers? Are you teaching preschoolers, or are you teaching high school kids? Again, that's a different issue. If you're teaching high school kids, where there's hopefully a little more common sense about separation and things of that nature, maybe you're not so bad with the proper protection and the proper distancing and everything. If you're treating preschoolers where they may not be able to tell you things like that, it's probably not a good idea. But again, I don't know why you have a low white count or a low neutrophil count. If it's due to your treatment, well, a lot of CML patients have this. How low is it?
Mm-hmm.
Is it the kind of thing that would really make you at risk? Is it the kind of thing that would send you to the emergency room? Is this the same person who was told to go to the emergency room if they had a fever? If their neutrophil count, say, is below 1,000 or something of that nature? It's a broad question to try and answer.
Okay, thank you. So there's one question here that we addressed already, but I just wanted to quickly touch on it. Are blood work services at PMH business as usual during the COVID pandemic? Yes, they are.
Yes. And in fact, it's easier. People are in and out a lot faster.
Okay, that's great. Does COVID appear to have a short-term effect on the heart?
Oh, wow. Well, the people actually die from COVID have multi-organ collapse, or kidneys collapse, or heart collapse. Is someone who's got an asymptomatic or a COVID infection that doesn't send them to the hospital? I think we're going to have to wait to see down the line. I've not heard reports that there's that effect.
Mm-hmm. Okay, so I'm looking at some of the questions.
Let me divert for just a second. We do know that certain viral infections can cause something called a myocarditis, or an inflammation of the heart muscle. And this results in people suddenly needing it so bad they require a heart transplant. We do see that with certain viruses. Whether COVID would be one of the viruses that does that, or if it does, higher frequency than in influenza virus or paraflu or one of the other ones that may do it, I don't know.
Okay, thank you. All right, so now we're 3 minutes out before the session wraps up, and I'm seeing quite a number of questions actually that are coming in regarding whether or not people with CML are immunocompromised. And I know that we've covered this already, but I want to throw it back at you one more time.
No.
All right.
And I again refer everybody to the ICMLF Foundation website. There's an answer to a lot of these questions.
Okay. All right, I think we're pretty much done our questions. One last one about Bosulif. We did address concerns about shortages in CML meds, but someone was specifically concerned about Bosulif, whether or not the supply chain has been interrupted by COVID.
Having talked to the Pfizer people just yesterday, the answer to that is no. At least they're unaware it has been. Now, it may be interrupted at the local level. Sometimes wholesalers don't have it and they don't have it for pharmacy, but coming out of the Pfizer itself, there's apparently no shortage.
Okay.
So if someone says they can't get any of their drugs for whatever reason, find out if it's a problem with the wholesaler or not.
Okay, how would you do that?
Ask. If the
Ask the
pharmacist says
pharmacist.
we can't, the pharmacist says we can't get it, ask them if they've tried more than one wholesaler. Try a different pharmacy. Now, I know, and if you're in a small community, you often don't have that option. But if you're in a larger city where there's more than one, go to someone in a different chain. If you go to Rexall and you're told that, try someone at Shoppers. They use different wholesalers. If you're in a place like Toronto and you're seen at one of the hospitals, try a hospital pharmacy. Sometimes the issue is that with the wholesalers, they just don't want to deal with certain people. And their excuse is you can't get it. And I've heard that more than once. And it's not just with CML drugs, it's with other drugs. Someone's wholesaler decides they don't want to cover this particular blood pressure medication. So they tell the patient, you can't get it. Well, it's not true.
Okay, last question. Would you disinfect your groceries?
That's a really good question. Well, I would obviously wash produce, things of that nature. COVID supposedly doesn't last on paper for an extended period of time. I actually am aware of people who do not have CML who are bringing in their groceries and letting them sit on the floor for 3 days before they open the bags. But I don't know who did the initial shopping and pulled them off the shelf to begin with. I'm not sure that we're not, put it this way, we're not seeing people like this, like who are the ones getting routinely infected. Again, 80% of the deaths, the serious cases, are in nursing homes, old age homes, people taking care of them, people who have functioned or done things with dense crowds, not obeying the self-isolation issue. I think if you're obsessive compulsive, then you disinfect your groceries, but I'm not sure it's going to do very much.
Okay, thank you. I think that we have reached the end of this very exciting session. Thank you so much for your time, Dr. Lipton. We all very much appreciate it. And if anyone has any burning questions that we didn't address tonight, feel free to pass them on to me at info@cmlnetwork.ca. And Dr. Lipton, I don't know if there's anything else that you wanted to add before we sign off.
Yeah, I think one of the things is discuss things with who's the physician taking care of you. Make sure they're giving you answers that they're getting from having information and not what they think might be occurring. As I said, the ICMLF website is very good in regard to COVID. There's a number of references to papers. Ask. And find out when someone tells you something, ask what the evidence is. I think that becomes very important.
Okay, awesome. Thank you very much for taking your time out today. Really appreciate it. I know you're still at work. You must be exhausted. Thank you very much, and stay safe out there, okay? And thanks everyone for logging in. We really appreciate it. And all of you, please stay safe as well, and try not to worry so much. See you soon.